Hello, everybody. I would like to welcome you to today's episode of Brain Pet Talks. These talks are supported by the company Postrigo, which is a pioneer in nuclear medicine imaging technologies. Today, the focus will be on current and emerging treatments for Alzheimer's disease. We are very happy to have Professor Rafii from the Keck School of Medicine of the University of Southern California with us. Professor Michael Rafii is board-certified neurologist, medical director of the Alzheimer's Therapeutic Research Institute, ATRI, and professor of clinical neurology at the Keck School of Medicine. He serves as director of the Medical Safety Unit of the NIH-funded Alzheimer's Clinical Trials Consortium, ACTC, where he and his team provide oversight to the safety and conduct of ACTC's entire portfolio in clinical trials. He's also co-director of the clinical core of the Alzheimer's Disease Neuroimaging Initiative, ADNI, and co-principal investigator of the Alzheimer's Network of Treatment and Diagnostics, ALZNet. Dear Professor Rafii, we are looking very much forward to your presentation. The floor is all yours.
Thank you so much. It's a pleasure to speak to you today about some of the recent advances in therapeutics for Alzheimer's disease. My name is Mike Rafii. I'm a professor of neurology at the Keck School of Medicine of USC and medical director of the Alzheimer's Therapeutic Research Institute. These are my disclosures. So as we have been thinking about Alzheimer's disease for the past decade, we have come to understand that there are several biomarkers that help define this continuum of Alzheimer's disease. And on the x-axis, you have the various stages of Alzheimer's disease. And on the y-axis is the level of abnormality across different biomarkers. And you can see different color-coded biomarkers that become abnormal as the disease progresses from an asymptomatic stage to a symptomatic stage. And the red arrow indicates the initiation of the dementia symptoms where Alzheimer's disease is typically diagnosed. Now, Alzheimer's disease, just as a reminder, is thought to be driven by a key pathogenic change in the brain. This is the production of beta amyloid by various pathways. We have genetic forms of Alzheimer's disease, such as autosomal dominant Alzheimer's disease and Down syndrome-related Alzheimer's disease, where the amyloid precursor protein, shown here in the center of the screen, as it is being cleaved by various enzymes, leading to an overproduction of beta amyloid that first develops monomers, then oligomers, and it eventually leads to amyloid plaques and subsequently neurofibrillary tangles. Plaques and tangles being two of the key hallmarks of this disease. And we know that there are individuals who have mutations, autosomal dominant mutations in the enzymes or in APP itself that lead to overproduction of A beta and developing an early onset form of Alzheimer's disease. Individuals with Down syndrome who have an extra copy of chromosome 21, which has on it the gene for amyloid precursor protein, also leading to overproduction of beta amyloid. And there are individuals who are disomic for APP, although they have trisomy 21. Those individuals with Down syndrome do not go on to develop Alzheimer's disease. And finally, there is a protective mutation, the Icelandic mutation within APP, that prevents and reduces and prevents the cleavage by the base enzyme, also being protective by reducing the amount of beta amyloid that's produced over the lifetime and reducing the risk for developing Alzheimer's disease. So APP and amyloid are thought to be key drivers of this condition. In sporadic Alzheimer's disease, it's thought to be less about overproduction of beta amyloid, but rather under excretion of beta amyloid. But the presence of beta amyloid in the brain reflects the initiation of disease pathology. In fact, about a third of individuals over the age of 65 who are cognitively normal, in fact, have elevated brain amyloid, and we refer to this as preclinical Alzheimer's disease. On the far left are PET scans showing, again, on the far left, cognitively normal individual. In the middle, a cognitively normal individual with the deposition of amyloid in the brain. And on the far right, an individual with symptomatic Alzheimer's disease. And you can see the progression in terms of increased amyloid in the brain on PET scanning. And on the right, there are several groups here shown from the Harvard Aging Brain Study showing cognitively normals on the left, mild cognitively impaired, and Alzheimer's disease dementia, with each circle indicating an individual. And you can see on the y-axis the level of amyloid in the brain. This vast majority of individuals who are cognitively normal have lower amounts, the red dash indicating sort of a threshold of amyloid positivity. And you can see that in patients with mild cognitive impairment, significant numbers, the majority have elevated amyloid, and those with dementia also have elevated brain amyloid. And this amyloid takes a long time for it to manifest the clinical changes. So this is data from the Alzheimer's disease neuroimaging study. And what you have on the x-axis is the years from baseline, and the y-axis is a score on a cognitive test. On the left is a preclinical Alzheimer cognitive composite, or the PAC, and on the right is the mini mental status exam, or the MMSE. And what you'll see is that the individuals were categorized into two groups: those who had normal brain amyloid levels in blue, and those who had elevated amyloid levels in orange. And what you can see is that over 10 years, there is a clinical decline on the PAC. The scores decline on the PAC. Roughly about 3.5 years after follow-up, you start to see the differentiation, such that by about 10 years, there is a significant difference in their scores. And the PAC is thought to be sensitive to early cognitive change that's amyloid and Alzheimer's related. On the right, you can see the MMSE, the mini mental status exam. This is a much shorter test, and it's out of only 30 points. And what you can see is that the individuals with elevated brain amyloid, about 6 years after being followed, show cognitive decline on the MMSE, and that this is seen really dramatically at 10 years. Also, by differentiating individuals as being positive for elevated brain amyloid or having normal brain amyloid, again, in the orange, those with elevated brain amyloid, you can see they have increased ventricular volume, which reflects brain atrophy, and they have a smaller hippocampal volumes, also reflecting AD-specific brain atrophy. Now, we've been talking about amyloid and the detection of amyloid even in cognitively normal individuals defining preclinical Alzheimer's disease. Amyloid is just one part of the pathogenesis of Alzheimer's disease. A second and very important component are neurofibrillary tangles. These are intracellular pathological changes that are thought to be related to abnormalities in the scaffolding that maintains the neuronal structure. And what's interesting about neurofibrillary tangles is that where neurofibrillary tangles occur regionally in the brain really defines the subsequent atrophy and also the clinical symptomatology. Here on the left are images showing the areas where there's tau PET pathology seen on PET scanning, overlaid on MRI, and you can see in areas where the hippocampus is involved, or medial temporal lobe, memory is the main symptom. Those with occipital lobe deposits of neurofibrillary tangle, or a signal of tangles within the occipital lobe, have visuospatial abnormalities, and those with the lateral temporal lobe abnormalities in tau have language problems. And this is distinct from amyloid, where you can have significant amounts of amyloid in the brain, but it's really when the tipping point is reached and tau pathology develops where symptoms really manifest. And on the right, we have MRI, tau PET, and amyloid PET across 4 individuals, a 75-year-old who is normal, and you can see that there's really no tau pathology and minimal beta amyloid, a 79-year-old who is normal, who has a slightly decreased mini-mental status exam score with some beginnings of amyloid, and a 70-year-old with mild cognitive impairment. And you can see this individual has a lower mini-mental status score. There's a bit more atrophy in the brain as seen on the MRI, and there's tau pathology and amyloid pathology. And finally, at the very bottom, a 68-year-old with the dementia syndrome due to Alzheimer's disease with significantly enlarged lateral ventricles on the MRI, widespread tau pathology, and certainly widespread amyloid pathology. In fact, we are now able to stage Alzheimer's disease using the ATN classification scheme. The ATN is the amyloid tau neurodegeneration biomarkers that are used to classify someone as whether they are positive or negative for amyloid tau or neurodegeneration. And these align quite nicely with both the diagnosis and the prognosis of individuals with Alzheimer's disease along its continuum, such that those who are amyloid positive, tau positive, and have evidence of neurodegeneration have a high likelihood of having probable AD dementia. Now, the therapeutic landscape of Alzheimer's disease has changed dramatically in the past few years. We've now had accelerated and then traditional approval by the FDA for lecanemab. We've had traditional approval for donanemab being expected later this year. And these monoclonal antibodies are entering into clinical practice. Now, how do the amyloid lowering antibodies work? I have shown here on the left again, that pathway from APP to the production of beta amyloid. And I've drawn where lecanemab and donanemab target amyloid. And I've added gantenerumab, another monoclonal antibody that's been in development for over a decade, and how it targets along the amyloid cascade. And there are different ways that these amyloids function in terms of their mechanism of action. They can block oligomers from forming into longer oligomeric chains. They can slow down fibril elongation. The antibodies can initiate plaque phagocytosis by resident microglia in the central nervous system. And the antibodies may assist in the efflux of beta amyloid from the brain through the blood-brain barrier. There are multiple mechanisms that anti-amyloid antibodies have their mechanism of action to essentially reduce or remove amyloid from the brain. Now, the first drug I will talk about is lecanemab. This antibody was tested in the Clarity AD trial. This was an 18-month multi-center double-blind phase 3 trial in early AD. Early AD is defined as individuals who have either mild cognitive impairment or mild dementia with evidence of elevated brain amyloid. And this trial met its primary endpoint. At 1,795 participants, lecanemab was given IV every 2 weeks, or they received placebo. Primary endpoint was a CDR sum of boxes at 18 months. And there were several key secondary outcomes, including amyloid PET. And this treatment had received accelerated approval in 2023 based on phase 2 data that showed brain amyloid reduction of approximately 73% at 18 months. These are the top-line results from phase 3 Clarity AD. On the left, you can see that the lecanemab arm, as compared to placebo, had a slower cognitive decline over those 18 months. And you can see that the separation increases with time. On the right is the amount of amyloid in the brain as assessed by PET. Again, yellow is lecanemab, blue is placebo, and you can see that roughly 75% or 77% of amyloid was reduced or removed at 18 months. There are unique adverse events associated with monoclonal antibodies targeting amyloid. This is thought to be due to the interplay between the removal of amyloid that's not just in the plaques, but also deposited within the endothelium or the blood vessels in the brain. And amyloid-related imaging abnormalities, or ARIA, are typically seen on MRI in the setting of the natural history of Alzheimer's disease, but to a greater extent with the use of anti-amyloid monoclonal antibodies. And you can see that approximately 14% of individuals on lecanemab, as opposed to 7.7% of individuals on placebo, had ARIA that is the hemorrhagic type. These are microhemorrhages, typically asymptomatic, and approximately 12% had ARIA-E on lecanemab and 1.7% on placebo. ARIA-E is the edematous form of ARIA, again, the majority being asymptomatic with detection only on MRI. Now, I wanted to spend a moment just to talk about gantenerumab and its phase 3 results. The Graduate 1 and the Graduate 2 trials each had approximately 980 participants. This was a 27-month long study, multi-center, double-blind, also targeting early AD. And here, gantenerumab was administered subcutaneously every 2 weeks. Again, the primary endpoint was CDR sum of boxes. And what we found with this study was that there was only an 8% reduction in clinical decline in those with gantenerumab as compared to placebo. There's been a termination of the gantenerumab program because of this negative result, but there is a reformulation that's in the works with phase 2 results having recently been presented at the ADPD conference. Now, why did gantenerumab not show the same level of amyloid of efficacy and perhaps amyloid reduction? And you can see that after approximately 12 months, only 24% of amyloid was reduced in one study and only 21% in the sister study. And in the 27-month time period, they reached 58% and 47%. So roughly half of the amyloid was reduced after over 2 years of treatment. And this may be telling us that the removal of amyloid needs to be within a shorter time period to demonstrate efficacy. Now, the third treatment I'll talk about is donanemab. And this was tested in a phase 3 trial called Trailblazer-ALZ 2. This was also targeting individuals with early AD. And this treatment met its primary endpoint, CDR sum of boxes, with a 36% reduction in cognitive decline at 18 months, and notably an 85% reduction in brain amyloid at 18 months, and approximately 75% reduction by 6 months. So it's a very potent remover of brain amyloid. In terms of its safety profile for donanemab, approximately 27.5% of individuals on donanemab had ARIA-E, and 0.8% of those on placebo experienced ARIA-E. About 30% experienced ARIA-H, and 7.2% experienced ARIA-H who were on placebo. Again, this is the typical natural history of microhemorrhages in the setting of having amyloid in the brain. Donanemab is expected to be approved. It is given 1,400 milligrams IV every 4 weeks. But I wanted to make a point about the trial design of donanemab. The treatment for donanemab was given until the amyloid PET was below 25 centiloids, at which the dose was lowered to 700 milligrams. And if the amyloid fell below 11 centiloids or below 25 centiloids for 2 consecutive scans, the participant was actually switched to placebo. The drug worked so well that there was a limited number of individuals who had received 12 months of exposure data. And for that reason, accelerated approval was not given on the phase 2 data due to this small number of individuals that were receiving treatment at 12 months. However, the phase 3 data did have additional exposure data that should help with its review. Just a cross comparison here, it does appear that the treatments, and here I'm showing aducanumab, which was the first anti-amyloid monoclonal antibody to be approved. They have different levels of ARIA-E and ARIA-H. Again, the vast majority of ARIA-E cases have been asymptomatic and self-limited. 6% were symptomatic, and 2% have been symptomatic and serious across these treatments. And there have been lots of studies looking at the percentages of symptomatic ARIA-E, SAEs related to ARIA-E as compared to the two treatments. And you can see that in lecanemab, 2.8% had symptomatic ARIA-E, 6.1% on donanemab. SAEs related to ARIA-E was 0.8% in lecanemab and 1.5% in donanemab. In relation to ARIA-H, 0.7% in lecanemab and roughly the same in donanemab, and SAEs related to ARIA-H were 0.6% in lecanemab and 0.5% donanemab. Again, most ARIA cases are asymptomatic and seen on radiographic images. On the right, you can see examples circled in red of ARIA-E on the top and ARIA-H, which are these punctate black spots referring to hemosiderin deposits. Typically, if they are symptomatic, are mild and self-limited, but rarely serious complications can occur, including death. There are now appropriate use recommendations that have been published to reduce ARIA in clinical practice, certain criteria for the clinical site and the health system's readiness, the conservative inclusion-exclusion criteria that will help prioritize patient safety, pre-treatment ApoE testing, which also informs the risk-benefit. Those individuals who have ApoE4 allele are at a higher risk of having ARIA. And of course, MRI surveillance for ARIA with MRI during its first year of treatment. CMS has, or Medicare will cover monoclonal antibodies and the associated imaging needed for treatments that receive traditional approval under the Coverage with Evidence Development or CED program. There are several registries now, one by CMS and one from the Alzheimer's Association called ALZNet. These registries will help also collect real-world evidence to understand the long-term safety and efficacy of these treatments. So back to the original figure that I showed, you can see again the continuum of Alzheimer's disease from the pre-symptomatic through the dementia stage. You can see the changes that occur across the various biomarkers. And I will point out that lecanemab and donanemab are in the MCI mild dementia phase of the disease, but in fact, we believe that by treating the key pathological feature of Alzheimer's disease, that is A-beta, earlier in the course of the disease, we may in fact see better efficacy. And we're seeing hints of this in the data from the trials that have been conducted, where those with the least amount of brain pathology, specifically the least amount of tau pathology, seem to have the greatest benefit. We are now conducting a trial called the AHEAD study. It is two sister studies, A3 and A45. These are individuals who have 40 or greater centiloids of amyloid in the brain, or individuals who have 20 or greater centiloids of amyloid in the brain. And each study is testing lecanemab for the prevention of the onset of clinical symptoms related to amyloid in individuals who are in preclinical AD. So in conclusion, AD pathology begins about 20 years before the onset of symptoms. Biomarkers of Alzheimer's disease are now available to stage patients along this ATN-AD continuum. Amyloid-lowering monoclonal antibodies definitively reduce cognitive decline by about 30% in the early AD stage of the AD continuum. Earlier treatment may result in greater efficacy, such as being tested in the AHEAD trial and others. And the mechanisms of action besides beta amyloid may also result in greater efficacy. And we will be launching the Alzheimer's Tau platform, or the ATP study, testing combinations of anti-amyloid and anti-tau treatments in individuals who are on this continuum. So let me stop there and see if you have any questions for me.
Well, excellent, Michael. Thank you so much for this very interesting presentation. In regards to questions, and I have a couple here. Now, you talked about disease-modifying therapies and treatments in general. Do you think there could be even eventually be kind of a medication that prevents Alzheimer's disease going forward?
I do. I am hopeful that the amyloid-lowering antibodies administered earlier in the course of the disease, when there is less amyloid accumulated and less likelihood of that tipping point being reached where tau pathology emerges, I think that we have a good chance of slowing the decline greater than approximately 30% in the early AD phase. I would think that in the preclinical phase, we may be able to have a much higher level of being able to lower the rate of decline. In addition, combination treatments, as I mentioned, targeting both amyloid and tau, may be even greater in slowing down the progression of this disease.
Okay, excellent. Now, in regards to the treatments we have right now, or disease-modifying therapies, do you feel this will work for everybody, or do we might see some responders and non-responders? And if so, are there any kind of preconditions that you think are relevant, like age or probably the amount of amyloid in the brain?
That's a great question. I mean, we are trying to enter the era of personalized medicine with the ATN staging, similar to the oncology world, where grading and staging of different cancers has allowed us to tailor treatments that will provide greatest efficacy and the least amount of adverse events. Understanding an individual's age, their comorbidities, the ApoE status, the concomitant medications that they are taking, and of course, providing their ATN staging, we should be able to tailor treatments that are most appropriate for specific individuals, whether you need a very potent amyloid reducer to put them in sort of a remission by removing amyloid from the brain and maintaining them. There may be other mechanisms, for example, BACE inhibitors, that may reemerge as potential therapies that would allow for oral treatments that would maintain a lower production of beta amyloid. So there's a lot to think about in terms of phenotyping individuals in terms of the stage of Alzheimer's that they are in, to pick the ideal treatment that may have the greatest efficacy and the best tolerability.
Okay, and now a little bit, about the diagnosis. How critical do you think is the early diagnosis of AD patients? And when you look into the different methods about the diagnosis of AD patients, is there kind of a gold standard that you would point out?
Right now, individuals who are symptomatic, in my opinion, should receive evaluation for whether or not they have elevated brain amyloid to confirm the diagnosis, or at least the reason why they're having their symptoms. In my opinion, the combination of amyloid and tau pathology and assessing for those will help understand the underlying basis for an individual's symptoms, whether it's memory loss, abnormal behaviors, rigidity, falls, Parkinsonian symptoms. There are a whole host of neurodegenerative diseases that are considered tauopathies. So if somebody is symptomatic, in my opinion, they should have a full workup, and certainly amyloid imaging or CSF evaluation for noting whether there's elevated brain amyloid should be performed. It will also help us stage them so that the appropriate treatments can be provided. Right now, anti-amyloid treatments, but perhaps in the future, anti-tau treatments as well. On the research side, individuals who are asymptomatic may in fact have elevated brain amyloid. And on the research side, individuals who have a family history, individuals who have a concern that they're at higher risk, may participate in research studies that would evaluate them for the presence of elevated brain amyloid or tau pathology to see whether they would be eligible for some of the prevention trials that are ongoing. And there are several such studies out there. I've mentioned the AHEAD study, but these studies will also inform these individuals so that if there is a change in their clinical status, they would be eligible for the treatments that are currently approved.
Okay, well, thank you very much for these answers. I think we come to the end of today's episode of BrainPet Talks. I would really like to thank you, Professor Rafii, for this very interesting presentation and the answers to these questions. I would like to thank you all for your interest, your participation today, and look forward to welcome you to one of these upcoming episodes of BrainPet Talks. Thank you so much. Bye-bye.
Thank you. Bye-bye.